this computer. All right, so we're gonna talk about peds, right? And again, this is mostly peds that have to do with your boards. There are many, many, many other disorders out there for pediatrics, but this is mainly the ones that you need to know for your board. So this is a definite, not FYI, this is need to know. Talk about some diagnoses, explain what diagnoses are, kind of presentation, kind of some treatment ideas. What do you think when it comes to your boards? What do you think some of the key diagnoses are that you have to know for your boards for pediatrics? CP, good. MD, maybe CF. I actually don't cover that because most of CF comes into play when we talk about percussive therapy that you need to know for that. So Downs and Duchenne's, good. Believe it or not, just that autism is actually not even on the boards right now. I mean, they talk about autism spectrum disorder, but it's more like on a level of, that they're a sensory overload disorder, but it's not a real hard. They don't have a lot of hard questions on that, which kind of scares me. Yeah, it is kind of scary, right? Erb's palsy a little bit. I covered that, but even that, your chance of getting a question on Erb's palsy is really, really low in the pediatrics section. At last time that I looked at kind of some of the summary of board question, there was one. Torticollis, good. Yep, that's not a specific disease, but that's definitely one of them. And then also stuff like what's toe walkers? Yes, not necessarily diagnosis. Scoliosis, right? And then polio with poliosis. No, just kidding. And the other thing is premature birth, right? Because premature birth is a big thing, especially in our area for some reason. Premature birth is a really big thing, and I have my theories on that, but I guess you guys can kind of guess some of the theories on why we have more premature births in this area than other areas. Seems like cities tend to have a little bit more premature birth than anywhere else as well. So let's talk about the role of PTAs, right? So how many of you guys overall are interested in treating peds? How many of you, is there anyone in here that's specifically interested in that? Chris, okay, I wonder why Chris is. Jacqueline, is that? Nope, possibly Alex, good. Yeah, and I can imagine Bison probably wouldn't be. Ashley, maybe, right? I could see that, yeah. How many of you guys, how about this? Let me change it. How many of you guys would be interested in treating pediatrics in the inpatient setting? Versus outpatient. Okay, yeah, okay. It's a different world. Just to let you know that what I'm going to talk about today is a little bit more outpatient based. But in the inpatient world, it's, again, just like we talked about with spinal cord injuries and everything like that. It's about energy conservation, conserving what they have, and providing what they need, right? It's not necessarily, you're not going to fix a child with CP in, the pediatric ward. It's not going to happen, right? So I honestly say the hardest times I had was treating kids in the NICU. It just, it really opens your eye or your minds and your eyes to what the world is like when you're holding a baby that literally is not much bigger than your palm, right? And you're range of motioning arm or fingers, and you almost have to use a toothpick to range motion fingers. Not a toothpick, that wouldn't be very good, but like a swab or something like that. It's kind of sad to see babies that size. It's also really sad to know that if you go to the NICU, you treat a baby today, there's a good chance that tomorrow there's no baby, right? So that's kind of the scary thing with the pediatric side of things. Yeah, it is kind of sad, right? That's why you don't want to work in peds, Mike. Not like, you relate too close to them. Just kidding. The outpatient setting's a little different, right? Why do you think I treat kids? It's because, we're on the same mental wavelength. We get along really well. Then treating outpatients is a little different. Outpatient, because outpatient also includes when we're talking about orthopedic kids, right? There's a lot of orthopedic kids out there that we'll get to see. And some of you, even if you work as techs, have seen orthopedic kids where maybe they've come in with an ACL sprain or something to that effect. And it hasn't been traditional PT, right? Qualified PT must be accessible to telecommunications for PTAs at all times. I will say that in the peds world, you almost definitely have to have remote supervision or your 2,000 hours because it's pretty rare that a PT is on site. Most of the PTs that are on site are there to do evals only because literally, I mean, in this area, I think there's a 2-month backlog on most special needs kids. So it tells you that there's a high need for it, but the reason there's not a lot of people that do it is because money is not good for it, and it's not a sustainable business model. Initial visit must be established by the, that was a mental slip there. Initial visit must be established by the PT to establish plan of care. That is not PTA. We do not establish a plan of care. I was just to see if you're paying attention, honest. It wasn't that I typed that and wasn't paying attention. Regular scheduled documentation with the PTA, depending on state regulations, and supervisory visits upon request from the PTA to reevaluate. It's really big if you're going to be a PTA that treats kids to have a really good working relationship with your PT, because you're going to be in contact with them a lot. Kids can make rapid changes, both for the positive and the negative. So it's important that you're constantly talking about them. Can be used in pediatric settings with the exception of the medically unstable. In some states, that's not true. In this state, I don't see many PTAs in the NICU or the PICU. But in Pennsylvania, we were big in the NICU and PICU. If you had pediatric training, they often censor them because a lot of the inpatient hospitals don't have specifically people trained on peds. But again, the main reason here the APTA is saying this is because in the PICU and the NICU, there's so much of a chance for a status change. That just means you have to be a little bit more of an observant PTA, and if you notice a status change, get the PT, right? And the same thing as anywhere else. If we see a negative status change, right? If the patient declines, what do we have to do with our treatment? Like, say we come in and now the patient's on a vent, and they weren't on a vent yesterday. What do we have to do? Yeah, it has to be a re-eval. Exactly right. Thank you, ESPN. It has to be a PT re-eval. Anytime there's a decline in status, doesn't matter if it's an adult, if it's a pediatric, if it's a dog. Well, actually, we don't do dog physical therapy, but if there's a decline in status, there has to be a PT re-eval. What happens if maybe the baby's being seen in the PICU, right, pediatric intensive care unit, and now they're on the general pediatric floor? Yeah, we don't necessarily need a re-eval unless there's such a change in drastic status that it would warrant it. Like maybe in the PICU, the child wasn't even able to get out of bed, but yeah, it's backslide typically, Ashley, right? But here's a chance where it may need one. So the patient comes out of the PICU and is now in the, the general floor. Patient wasn't even able to get out of bed in the PICU, but now they're able to get out of bed and walk. Right, and that's it, exactly, Alex. So I'm talking about now mobility's changed. At the point that mobility has changed, they do have to be reassessed. And a lot of times it's not going to be a hard full-on eval. The PT is going to come with you. You're going to do most of the work. And they're going to assess the gait and transfers and stuff like that. So they can put in a note, right? And we can't document any of that until they've put that eval in, until they've updated their eval. We have to make sure they have that in there, or at least an addendum to our note. So it's really important that we can be used in this manner. And a lot of PTs really like good pediatric PTAs. It makes them really appreciate you if you are willing to work with those kids to get them better. So milestones, right? Milestones. All parents care about this. Well, asterisk. All parents that care about their children care about their children's milestones. This is a big thing with pediatrics. Especially, it seems like moms want to know what percentile children are in. It is the number one worry, yeah, right? Because as soon as you start seeing not meeting milestones, you start worrying about the worst, right? Oh my God, what if my kid has CP? Oh my God, what if my kid has Downs? And sometimes it's just you have a child with a developmental delay. It may not be any real big issue. I'm going to take my brother for an example. My brother missed a lot of his 12 to 18 month milestones, right? It took him a little bit longer. Now, one could also extrapolate that to all the other problems my younger brother has now, but at least once we got him to about 24 months, he kind of caught up in his milestones. He was just a little bit delayed compared to everyone else, right? And that's where we have to monitor those. But this is the thing, kids learn by their environment, right? So this is a real important thing we have to teach the parents is that if their kid doesn't get to interact in an environment, they're not going to develop, right? if the kid spends all day in the crib, right, is that kid going to have normal developmental function? No, right? Kids need interaction. Kids need interaction with parents, right? They need that bonding experience to make them more trustful of the world around them. Because there's a lot of studies have shown if kids don't get a lot of interaction with mom and dad, there are all kinds of trust issues that develop from being a child, right? Both good and bad, where they just start attaching to whoever they can, or they don't trust anybody. So all that comes into play here. Education is imperative to not only teach to the patient, but also to the family and caregivers, right? Especially in the case of like torticollis, which is not necessarily a developmental disorder, but it is a physical disorder. The parents have to be as equally involved as you are in therapy, right? I love getting siblings involved. I love getting big brother, big sister involved in all the treatments, because big brother, big sister, even though you may be later on when you guys start getting to the point where you don't like each other, don't get along, but when they're, some of you may have remembered when you were a kid that when big little brother, little sister came along, you were excited about that. You may not have been, and you may have been like, they're here to replace me. Yeah, that kind of happens too. Home exercises are important. The more the parents do the HEP, the more the child's going to progress. So HEP is super duper cooper important to pediatric settings. There are many different learning styles, right? But a child will only learn if they are interested in that learning. And this is something that took us a while to get on the kindergarten level, right? We used to just sit kids down and rote memorization and blah, 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 blah. But what we learned is when they're in kindergarten, are they worried about necessarily memorizing the ABCs? What do you think? Except for nerds like me? No, right? They're worried about that Susie's over there picking her boogers out of her nose and eating them, and they can't tell the teacher, right? They're worried about the environment around them. So the more that we can get them to interact with that environment while they're learning, the more they will learn, right? That's why we have a lot, you remember when you learn the alphabet, A is for apple, B is for bear. You associate words with visual representations, right? We used to, we don't even teach kids cursive anymore, so they don't have to worry about that. They just have to learn the letters, right? Milestones are not set in stone. So when a mom says, "Oh my God, my child missed this 6-month milestone," doesn't always mean there's a problem, but it's a warning sign. I have no idea, Russell. I think they just put an X, because I don't think they even teach cursive anymore. I guess the moms in here could tell me, but as far as I've seen in schools, they don't even teach cursive anymore. Or if they do, they talk about it, and this is fancy writing. I heard somebody say that before. Good, Jackie, good. And I think that's kind of, somewhat PE there. God, think of how much better it was when you were alive to come up through. At least you got physical education, right? I know that for me, I was the fat kid in school, so PE was probably the least favorite class for me. But I did learn stuff from it, like how to take a beating, how to get bullied, other stuff. But yeah, so I don't know how that went dark really quick. I think I showed my daughter, but that's right. It doesn't require them to know it. And man, when I was coming up, man, they beat that into you. Like literally. Sister Susie came by with the ruler and beat on you. No, just kidding. Get the whooping if you don't. On a special paper, exactly, right, Jenna? Right? And you better be able to trace right over the letters and be able to match them perfectly, or it's wrong. But there's a wide variety of ages. So what you're going to need to know for your boards as far as milestones go, get a good idea of what is kind of the top end of the milestones, right? A lot of time the boards aren't going to ask you about pediatrics, and I have yet to see a question about a pediatric child meeting their milestone early, right? They're not going to say, is this child meeting his milestones early? That's not the type of question they're going to ask you. They're going to talk to you about something like the patient presents with Babinski reflex and the child is 36 months. Has the child met the Babinski milestone? What do you think? So child's 3 years old and still has positive Babinski. No, right? The top end of that is 24 months. That's the ultimate end range where we want the child has to have it. At that point, it's going to start impairing walking, right? So that's kind of why we do this. So but the key thing here is the child doesn't learn the skill, it's never going to integrate and practice that skill, and therefore it's never going to attain that milestone. So it's really important they kind of go through this, right? Development of postural control is important, right? Sensory systems are really important for postural control. If they don't start developing feeling of what happens if I'm leaning forward, what happens if I'm leaning back, what happens when something bumps onto the bottom of my foot or bumps onto the palm of my hand, they're not going to learn postural control. What about a child that's asensate? Do you think they're going to have normal milestones? So what's asensate mean? It's exactly like it sounds. Yeah, no sensory, right? So a lot of times asensate is usually a patient that has no feeling, so they may be paresthetic, where they can't, or where they can't touch. They have paresthesia. Do you think that's going to have a normal milestone development? No, right? The baby can't tell when it's laying down or sitting up. It's kind of problems. And that can be a problem with all kinds of things. It can be a problem with the brain, it can be a problem with spinal cord tracts, all that fun stuff. Visual system is the predominant perceptual means of modulating posture. So a kid, as they're growing up, asensate. So hold on. Let me get my mouse over here. It's just another term for paresthesia, and literally means no sensation. A lot of times, if they're asensate, they lack both touch and proprioception, right? So that really affects their overall development. It's pretty rare, but it can happen, especially if you've got something like dorsal column damage or something to that effect. Vision, right? That's why what happens with kids when they feel like they're falling forward. Well, they may not always have that, but they can look and see that floor is getting closer to them, right? So vision's big, important for that first year. They need to be able to see. Can we do an accurate eye exam on a child that's maybe a year old? Could you please read the eye chart and tell me what the lowest letter is you can see on that eye chart? Exactly, perfect choice, right? We can't. It's really hard for a child to be assessed for vision. So what do you think we're going to assess with their vision? How do you think the doctor's going to assess it? Yeah, it doesn't develop till about, colors is the big, right? Colors is big. And that helps, determining, are they seeing things right? Tracking is important as well, right? And light, exactly. So all three of those are the kind of things, right? What do you think is a good thing to use for tracking for a child? Toy works well, yep. There's one more important thing. Mom. Yes, exactly, right? Baby should follow mom, right? Baby should know where mom is by the time we're kind of getting into the later points of tracking. You can just tell this by telling mom, okay, I need you to sit over here, I need you to sit over here. Does baby track mom? That checks on a couple of things, right? That's going to check on visual development. Is baby following mom with their eyes? And the other thing it kind of develops is, has baby developed that positive attachment to mom, right? If baby doesn't track mom, does the baby have a positive attachment maybe? What do you think? No, maybe, right? The other thing is, you can't be holding a flashy red toy in their face and look, follow mom, right? The kid's the flashy red toy is more important at that given moment than mom moving around the room, right? So you got to be able to, it's got to be independent. The babies can't multitask, right? And this is very apparent because when babies are starting to learn to creep along furniture, right? They get up and they start pulling on that furniture, and all of a sudden they see the toy in front of them and grab for toy, despite the fact that they forget they need those hands to hold themselves up there, and boom, right? Down they go. They don't have that multitasking skill. Vestibular systems activate in infants when vision is a problem, provides feedback and postural orientation. What specific test helps determine if their vestibular system's developing? You guys remember? Writing reflex, good. Which one's that? Right. The parachute, yes, good. The one where you lean them forward and they're feeling themselves fall forward, and all of a sudden their vestibular system kicks in and they push back, right? Remember we talked about in vestibular about Tumarkian crises? Do you remember a little bit about talking about that? Vaguely? Yes, no, maybe so? Tumarkian crisis, when we do that vestibular treatment on the patient and we sit them up and suddenly they get that forceful push backwards. Right? So that's why I said when you set the patient up after doing vestibular treatment, you've got to be on them, hugging them. Because a lot of times they're going to forcefully push backwards off the mat. There's a lot of signs that show that's a regression back. Hold on. Let me. There we go. Okay. I wasn't sure how to spell it, so I had to look it up. There you go. I was like, I would have totally spelled that differently, so I'm glad. Yeah, I wasn't. Yeah, it's not necessarily a sense of falling backwards. It's an overactivation of the anterior-posterior push of the vestibular canals. So the vestibular canals, when you sit them up, all of a sudden, it's actually what they do is they feel like they're falling forward, so they force themselves backwards. And they will then have the sense of falling backwards because they're going to fall backwards if you're not guarding them. And literally, it's not like this, oh, I feel like I'm going to fall. No, they literally are forcing back almost with a sense of like pulling away from you. But that's, I mean, there's a lot of, there's a study that we're working on right now. Is that just a regression to a pediatric reflex? Could be, right? Because think about it. What's that? What is the reflex? What is the parachute reflex? Protective. Okay. What's the term for it? What's the name for it? Writing. How about Moro? Do you remember that briefly? Not at all. Moro is part of the writing reflexes, right? Anytime that you see the baby kind of, right, it's an extension of the body. It's because the baby knows if I don't extend, I'm going to fall. That also leads them to a lot of falling on their butt, right? That helps them from falling forward because baby's head is usually what compared to their body? Yeah, heavy, right? That's why a lot of babies, until they develop neck control, kind of look like this, right? Kind of look like bison on a Friday night. Head hanging down like that, right? So they've got to develop that reflex that protects them from smashing their head when they're going forward. But still, babies get pushed backward. You know, babies, when they do that posterior push and fall backwards, sometimes can bump their heads. But a lot of times, if you watch babies, yeah, I mean, yes, fine, I'll give you that. They integrate at the same time, so it depends upon what you're doing. A lot of times, we're just going to test them together. That's why this is where it kind of gets into that kind of yeah, no, maybe, right? They integrate together, so they should both integrate it. Yeah, Jared's smart, right? That's why I'm like, yeah, maybe, right? Moro's more of that kind of startle reflex, whereas you know the parachute's more of that falling full forward. Yeah, okay, I'll give you that. You win. But yeah, so you have those reflexes that integrate that help the baby maintain their vestibular system, right? Because their vestibular system, right? What's our normal pulses per second in the vestibular system? Do you remember? 70 to 100. Good, right? 70 to 100 is that normal resting pulses per second in your ears. With babies, it's up to 100 to 120, right? So they are firing at a really high rate for protection, right? It takes a little bit less of a change to cause their vestibular systems to kick in. And that kind of makes sense, right? And as we get older, those pulses per second start dropping. So it takes a lot larger charge to make a change. And that's why vestibular becomes a problem when we get older, right? Somatosensory looks at providing position for limbs in space. You know, at 1 to 7 years of age, so this is, you know, we start getting into 1 to 7, what would you call those kids? Evil. Parasites. We're going from like the toddler age up into, you know, elementary school age, right? We're starting to get into that where the kid's developing. From 1 to 7, anytime perturbation's given where they're pushed, right? Distal muscles react first prior to proximal muscles, right? So that's why a lot of times if you push a kid, they're going to fall, right? And, you know, how many of you ever had a parent, maybe it was just my parent, my dad loved doing that to you as a little kid, just give you a little shove and tumble down you go. Right? Because your full writing reflexes haven't developed. They're there, but they're not on the full strategy that we have, right? They often don't have that step reflex that we have. That final kind of, okay, I'm going to fall if I don't widen my base of support. After 7, you start getting trunk extensors and you start getting that step reflex to protectively protect you from falling. Because at that point, you've learned falling is bad. Of course, still from like 7 to 10, kids think falling is just the greatest thing in the world. But, you know, they take falls that we would literally break every bone in our body and they bounce up and just go running. I've seen it. It's kind of sad. You watch these kids like fall down a full flight of stairs, get up and do it again. All right, so let's talk about cerebral palsy. The one thing that you learned from that video that I showed you with Zach is cerebral palsy is not a problem with the body. It's a problem with the brain, right? Legs and arms aren't broken. Head is. So would that be apraxic or ataxic or possibly both? Literally, it could be both, but it's primarily praxic, right? Now, there can be ataxic as well. There can be integration once they understand the plan to get it to work in, right, to send down those signals. But a lot of it's apraxic, right? But there's studies that show it's both as well. So what do you think? Why do you think that plan doesn't develop with these kids that have cerebral palsy? What do you think causes the plan not to develop? Yeah, lack of oxygen is what causes the injury to the brain, right? And then because they have the injury to the brain doesn't develop normally. And therefore, when it encounters that time where it would normally learn a plan, that plan doesn't get encoded, right? So I'm going to use touching something hot. When you're a kid and you touch something hot, did it take a little bit to realize, ow, that's hot? What do you think? Yeah, it does, right? But the next time you touch something hot, what happened to your reflex? Got a little faster, right? And now when you're an adult, for most of you at least, I don't know about all of you, but for most of you, when you touch something hot, it's a pretty instant reflex. Ooh, okay, nope, that's bad, right? Unless, of course, you're a lady at McDonald's and then whatever. They can't realize that a cup of coffee is hot. I mean, this wasn't even nowadays where there's actually cold coffee everywhere. This was when coffee was only hot and it had one flavor. It was coffee flavored coffee. Anyway, sorry, it's a tangent. So the development doesn't set in. So maybe you have a kid that's got cerebral palsy and they touch something that's hot. That signal gets sent up. It takes a lot longer to come back down afterwards. But even after the baby pulls off, that plan doesn't get saved to the hard drive, right? The brain is like a giant hard drive. Doesn't get saved there, right? So the next time they touch it, they've got to relearn it again, right? Or maybe they adapted a maladaptive pattern where they feel something hot and hold on to it longer, right? So there's all kinds of maladaptive patterns that can come along with cerebral palsy, right? It's a neurological condition, can occur in utero or shortly after birth. What do you think might cause a common development of cerebral palsy during or shortly after birth. So it would cause a lack of oxygen. Could be mother smoking. Okay, yep. That's typically during. Teratogens are during, before pre-birth. So what about when the baby's coming out of the birth canal or right after it comes out? What could cause an anoxic event? Right? Yep, tied, right? So the cord's tied around the neck is a big one. Right? Baby comes out. Fluid in the lungs is the other one. Good. Those are the two main ones. So you have the cord, the umbilical cord wrapping around the neck, right? And that just comes in, chokes off the oxygen for that patient, right? Or they come out and they have too much fluid in their lungs and the docs don't get it out fast enough, right? What's one of the things the doc wants to hear when the baby comes out? Crying, right? Crying indicates breathing, right? Also, obviously looking for color and stuff like that. So that's the important. Motor impairments and sensory deficits can involve one or more limbs, often the trunk as well, right? And common complaints, usually when they're a baby, they're a floppy baby, right? So floppy baby means everything's loosey-goosey. As they develop, they will get more and more and more stiff. But understand the whole time, even though they started kind of floppy and moved to stiff, they've always been a stiff baby, meaning they were always going to trend there, right? It's just that trending has the plan and the actual implementation plan hasn't gotten there yet. So they start off all floppy, and then they will develop into that kind of stiff and spastic type activity. They're so strong when I lay them on their tummy, they'll lift their head really high, right? And they'll look like they have advanced head control, but it's not necessarily advanced head control. What it is muscle spasm, right? And they'll try to arch their back all the time when they're on the floor, constantly look back. And the main idea is the body itself is almost going into, what are those two postures that happen with brain injuries? Decorticate, good. And decerebrate, good, yes. Right? Decorticate to the core, decerebrate out. So when the baby starts off and being floppy, a lot of times they look very decerebrate. And we talked about TBIs, primarily, absolutely, yep. You're exactly right, Ian. Good integration there. Decerebrate is worse, right? Decerebrate's the worst look we can get. Decorticate is bad, but not as bad as decerebrate. And Ian just asked, is CP primarily upper motor neuron? Absolutely. It's primarily upper motor neuron. That doesn't mean they can't develop lower motor neuron injuries as well, but it's primarily upper motor neuron because it's mainly brain and spinal cord. Great integration of that. So they're going to be classified based upon the area of the body. Are they monoplegic, diplegic, hemiplegic, and quadriplegic? What do you think monoplegic is going to mean? One limb, good. And then two limbs, and then half the body or all the body. I don't think I've ever seen a kid that was classified as tetraplegic, but I've seen kids that look like it. And then obviously they're going to be classified based upon the way they present. Are they spastic or are they flaccid, right? But remember, even if a kid is diagnosed as flaccid CP, where are they going to trend to eventually? Because you'll see kids that are classified as flaccid CP. They're eventually going to go spastic. That's where the head down the road is where they're going. So just understand that. And then, is the problem apraxic or is it ataxic? We have to look at those kind of things, right? Here's a kid with a nice little reverse walker, right? Why is the walker behind him for kids? Yeah, if he falls, right? Because they fall backwards. I'm going to move on. Now that I think about that question, I'm not going to answer that one. Classifications, degree of severity, right? They have the gross motor functional scale, talking about handout. I have that for you. It's going to be posted later today. I was waiting for the updated one to come out, right? This is kind of how we classify how functional they are. Diagnosis is usually assumed. So here's the deal. CP is not a hard diagnosis. It's not like they can do a blood test or a titer test to determine if a kid has CP. But what they will do is they'll look at are they attaining their motor milestones, and do they have abnormal muscle tone and abnormal muscle patterns? If they have A, B, and C, then they have CP. That means CP is that umbrella diagnosis, right? It's not necessarily a hard diagnosis. Looking at impairments, is it a single system impairment? What's going to happen? It's usually muscular and skeletal, even though the pathways from the brain. I said again, it's a brain problem, not a muscle problem. Impairments, insufficient force generation, spasticity, abnormal extensibility, exaggerated hyperactive reflexes. All that looks like upper motor neuron injuries. Go forward. There you go. Secondary impairments can be malalignments such as torsion or hip deformities. They can have scoliosis. All that can develop. They can have multi-system impairments, right? So what if ataxic and apraxic? No, so is ideomotor and ideational more apraxic or ataxic? Do you remember? Apraxic, good. There is some studies that are starting to talk about ideational ataxia, but it's not on your boards right now. So when you think ideomotor or ideational, look for apraxia. For now, don't even start throwing that in there. Don't even get your mind confused there yet. That's next level pediatric stuff. Don't fry your brains. Let's think about it. So I've got a brain injury. My brain injury causes my core to be tight and in like this. What other secondary complications am I going to develop from this? Breathing, good, right? What about blood flow? Nerve damage potentially, right? Yeah, especially here. So that's the thing. The primary impairment is going to be that brain injury. And then maybe the spasticity that goes with it. Thoracic outlet syndrome, good. But they're also going to have secondary impairments that go with it. So don't always dismiss they're saying, I've got pains that go along with it. Oh, you've just got cerebral palsy. They may have it because they're having all these secondary impairments that go along with it. Welcome. A lot of times they're also, these kids don't necessarily, because they're not learning right, they learn maladaptive patterns to do things, right? Maladaptive means not normal, a bad way of doing things, right? So when we teach them to get out of bed with log rolling, they've maybe learned that they fall face first out of bed because it helps them get out of bed easier, right? So we've got to make sure we change those things. We've got to help their posture. We've got to help their breathing. We've got to help all of that. We've got to encourage that energy conservation, proper breathing to get to more functional status. They also usually have decreased learning ability, right? It makes sense. If they've got a brain injury, they're going to have a little bit of decreased nerve injury or learning ability. That doesn't necessarily mean they are mentally retarded. It just means it takes them longer to learn things. And they get frustrated really easy. So this is kind of stuff we're going to work on. Family education, handling care, everything like that. Preschool, we're going to look on limiting impairments and preventing secondary impairments, right? So at that point, we've got to look at how can we keep them from getting worse, right? Because we know in that preschool to elementary period is our peak plasticity period. So if we can help them then, there's a better chance of them developing a little bit more normally later in life. Casting orthosis is a big, especially with CP. A lot of kids are toe walkers. Again, toe walking doesn't always indicate CP, but it's a good sign of CP. Interventions, activity limitations, mobility and play is going to be big, right? Why do you think a lot of these kids with CP may not get the same amount of play time as the other kids? And this is the kind of the sad part about this. Overworked muscles may be good. But what about other kids in their school? Are they going to want to play with the kid? Johnny's got to walk with the walker, and he walks a lot slower than I walk, and I want to go out and play kickball. Yeah, there's going to be bullying, right? There's going to be a little bit of bullying. But the other thing is they just don't get that same interaction, right? And it's really sad when you see these kids out in the playground and they're off by themselves. They're over watching butterflies or something like that because they can't play kickball. There's a great autism commercial now talking about integrating kids that have autism into normal play. Right? So that's kind of important. So school age, we want to look at one-on-one PT, PTA care, right? Monitoring by the PT, monitoring by the PTA, establishing management programs. We want to start developing an IEP and an IDP for these kids. right? An IDP is kind of an educational plan that helps not only with their education, but also helps with their motor development. Looking at how school environment may need to be changed, right? Because they may have different requirements for schooling. They may need some extra help. So we have to be looking at this. This is kind of that where we get into that, should these kids be in the same class as regular kids? That's one of the things we kind of look at. We get school age, reduced primary impairments, orthopedic surgeries may be needed, activity, mobility, and endurance, school and community. And here's the deal, CP kids transition to adulthood. They'd eventually become CP adults, right? As long as they don't have compromises otherwise. They may not lead as active a life as a normal adult, but they can transition to adulthood with fine, right? And we have to teach them life skills. How are they going to become an adult? Down syndrome, we also talked about this, right? Trisomy 21. There's a lot of different sensory deficits that come with this, right? Cataracts, myopia, farsightedness, strabismus, nystagmus. It's mild to moderate hearing loss often, and mainly because of otitis media, meaning the inside of the ear is often inflamed, right? Cardiopulmonary is a big one, right? What's going to happen to the kid with the trisomy 21? Why do you think their cardiopulmonary is going to be poorly developed? Are they hypertonic or hypotonic, first of all, typically? Somebody with Downs. Anyone know? Yeah, typically hypotonic, right? Don't let them, again, I've told you this before, don't make that think that they're weak, though, but they are hypotonic. Yeah, exactly. So if they're hypotonic, that goes down to the heart too, right? The heart becomes hypotonic, right? So I just got a message. What's strabismus? Does anyone know? Strabismus. So obviously, if I'm talking cataracts, myopia, farsightedness, and nystagmus, what am I dealing with? Vision, right? So hold on. Let me see if I can do it. Yeah, cross-eyed. Exactly. God, that actually messed up my vision for a little bit. Right? So typically strabismus is a cross-eyed effect, right? That could be muscular, could be nerve-related. They typically have cardiocongenital heart defects. I can speak today. Atrioventricular canal defects, ventricular septal canal defects. Overall, the heart's just not developed right. Decreased stature is common. They usually don't get as tall. Have any of you ever watched there's a whole show about Down syndrome. I can't remember what it was called. But it's usually, I think it's on either Lifetime or TLC, because TLC has all those shows. But most of the people that are on the show aren't of normal stature, and they're adults, because they just didn't develop that way. Hypotonia is big, ligamentous laxity, especially at the analaxial joint, so at the head, right? So brachiocephaly is common. Fontanelles are usually larger than normal and longer to close. What are the fontanelles, first of all? See if you remember that from anatomy. What are your fontanelles? The sutures, right? They're when they're underdeveloped. Yes, the folds in the brain, everything kind of doesn't develop properly. Underdeveloped facial bones. It's really common for the face just to not develop normally, and they take on this kind of what's called simian appearance, right? Abdomen may be slightly protuberant, secondary to hypotonia, so that abdomen doesn't tighten up. They don't get a six-pack, right? They start developing, and they're already at the full kind of Dunlap, so their belly's already kind of Dunlapping down because of their disorder. Chest may be abnormal, right? They may develop an abnormality with the chest wall. They often have an umbilical hernia. Hands and feet tend to be small, and then they have a wide space between the first and second toes with a crease running on the sole of the foot, right? So they have this called simian line on the foot. So a lot of times they're big toe, right? So that first and second toe, there's a large gap between them. Now, don't look down at your feet right now and go, oh my God, I've got Downs. There's always going to be a little bit more of a gap between those toes, right? But it's an excessively large gap. Could that cause problems with proper footwear? Well, I mean, I'll let you be the judge of that, Ian. Yeah, it could cause problems with proper footwear. Absolutely. The main thing here with children with Downs, the main thing we're going to be focused on, or at least precaution-wise, is atlanioaxial instability. We are going to protect the head and neck. So that means they should go out and play contact sports, right? Yep. Sounds like a good idea, doesn't it? Yeah, no. Right? But do you think these kids still want to play contact sports? Sure they do. A lot of them do. Because why do they want to play contact sports? Because all the other kids are playing contact sports. I don't understand why I can't do that. They don't have, the kid doesn't understand that they have this disorder. A kid wants to be a kid. If they see kids bashing their heads together and playing football, they want to go bash their heads together. Sounds like fun. Concussions are great. This is very true. This is very true, Russell. You're right. They probably do have more stable ankles than Justin. We want to promote anti-gravity control and weight bearing, right? Working on extension. The main idea is we don't want them as a child and an infant to start developing this type posture, right? Because the longer they develop this type posture, the harder their breathing becomes, the less their heart functions. Oh, not the wrong way. What happened here? There we go. Activity and mobility and endurance needs to be taken care of at school age. So here's the deal. They hurt you. I know your ankles hurt you. Down syndrome kids, we need to get them active. We need to get their endurance up, right? Because it takes them a lot more to do the things that you and I would normally do. So you have to be constantly working on endurance with them. And then when we transition to adulthood, right, we need to plan them. What are they going to need? Are they going to need constant support? A lot of them do. Are they going to be able to live normal lives? Some of them do, right? So this is the big thing. And especially employment, right? It's really, I don't say really easy, but it's easier to spot somebody that has trisomy 21 that's coming in for an interview. And is there going to be underlying bias against that person? Yeah, there is. It's a sad thing to say, right? And you'll hear people say, nope, I am not biased against anyone. It doesn't matter if it's a man, woman, transgender, tree, somebody that identifies as a tree, or they come in and, they've got 3 eyes and 4 nipples. I do not discriminate against these people. They're going to say that. There's inherent bias. We all have it, right? The best thing you can do about your own inherent bias is work towards it, right? Improve your bias. You all have a little bit of inherent bias. And if any of you say you don't, I have my own inherent bias. I know I do. I work on it constantly, right? Zappos does hire a lot of Down syndrome. Well, and that's the thing, Mike, is a lot of them will require long-term caregivers. And, here's the deal is Downs cost the government and medical insurances a lot of money, right? It does. And we have records going back showing that Downs isn't something new, right? Downs has been present all the way back to ancient Sparta. They've actually found some skeletons and stuff like that from Sparta that show that a lot of times there were births, mainly because Sparta was a warlike nation, and they had children later in life because of that. And there are a lot of studies that have shown that some of the skeletons found are typically Downs formation skeletons. They fall under Disability Act when it comes to renting. Yes, they do. Absolutely. They fall under the inability to discriminate due to disability, but the problem is most of the people that are going to discriminate will find some other reason. They just do. It's sad. Right? But yeah, so they may need long-term care, Mike. It's kind of sad. Right? Most of the adults I've met that have Down syndrome, and there's some great, I'll have to see if I can find, there's a Down system support group in town here. See if they obviously aren't having meetings now, but I'll have to find out when they go back together if they have meetings. It's really nice to go to one of their meetings because what I find, they're the nicest people in the entire world. And they want to tell you about their lives. They are super positive. They want to tell you, like last year I wasn't able to walk a mile. Now I can run a marathon or run 5K. they are really, really super positive about life. Yeah. Once they get older, they're definitely consistent about PT and guidance, right? They are huggers, though. You're exactly correct. Um, but why do you think people become a lot of those may become huggers? Because they may not have gotten enough of that as a child. It's true, right? But I mean, I've been to a couple of their meetings, and it's such a breath of fresh air compared to going to other type meetings because they just really, truly care about life, right? They want the best thing. Even if, it's funny is even if they get discriminated on, do you know who they usually blame? Themselves. Yeah. Right. How messed up is that? Right. If they get discriminated on, they're like, oh, it's probably something I did wrong. That no, it's just inherent discrimination. It is. It happens. Right. But it's really, they're just super positive people. And a lot of times they want to do better, which is huge, right? That's a huge drive in life. They want to get better, whether it's getting better at just being a normal person or just getting better in physicality. They do. They want to get better. A lot of times once you get past like the 7-8 range, that's when you start getting a little bit more involvement in PT. Before the 7-8 range, they're a little cantankerous and they really like to bite. Just to let you know. Spina bifida. Spina bifida is a failure to close the caudal border of the neural tube, right? The spinal cord. Can result in a meningoceal, spina bifida aperta, spina bifida cystica, spina bifida diaphragm, and myelodysplasia. Wow, that's a lot. Mr. McKeever, that scares me. Well, that's okay, because the ones you need to know primarily, myelomeningocele, meningomyelocele, or just meningocele is the other term for that. Spina bifida, is the thing they don't have there is occulta and spina bifida aperta. Right? Those are the primary ones you need to know for your boards. The other ones you'll develop if you work. The main thing with these is it just, when you see a big fancy word like that, all it's doing is telling you how the defect presents itself, right? Which one of those is the worst? Do you remember? Is it meningocele, myelomeningocele? Yeah, myelomeningocele is kind of the worst because myelomeningocele, right, means that they've got not only the meninges involved, but also the what? Not myel like that. The myelin sheath, the right, so getting down to the nerves, right? The nerve fibers themselves. So the spinal cord is out into that meningocele, right? It's the spinal cord, right? Spinal defects usually diagnosed at birth with the presence of an external sac on the body's lower back, typically in the lumbar region. They can now see these in utero, so they can actually detect these a little bit earlier now, which is really good. The sac has the meninges, maybe some cerebral spinal fluid, spinal cord protruding through that dorsal defect in the vertebrae. So there's an opening where that spine didn't close, and now there's a bulge of the spinal cord coming out the back. Now, it may just be just the sac, so it's just cerebral spinal fluid. It may be the sac plus some of the meninges. It may be the sac, the meninges, and some of the spine, right? So that's the kind of thing, the worse it gets, the worse the prognosis, right? Occulta and myelomeningocele have less severe abnormalities. Occulta meaning hidden, right? And usually means the vertebral arches haven't fused. So usually the neural tissue is not affected there, but oftentimes when the baby's born, they'll have a small tuft of hair on their low back, and that kind of indicates that there's a spina bifida that's going on. They may not have any impairments, but the spinal cord didn't close completely, right? Meningocele is protruding sac containing meninges and CSF. And remember, the meninges are contiguous with the spine and the brain. So that means if you have that bulge where that meninges is being pulled out, that means it's also pulling down on the meninges of the brain, which can affect overall brain development. Lipomeningocele is superficial fatty mass in the lower lumbar sacral region, right? These patients will usually have a lot of problems with bowel and bladder, mainly because the cord gets stuck. So if they develop this fatty substance in there, it's going to typically bind down everything else. And a lot of times these patients are going to have surgery before they, as soon as they possibly see it. Disability causing locomotor dysfunction. A lot of times it's dealing with the lower extremities, right? So pes calcaneus, calcaneovalgus, varus, Talipes craniovarus, right? Club foot, pes equinus, flat foot, convex pes valgus, they call rocker bottom foot. If you ever want to know what that is, think of the old Sketcher, what were those shoes called that Skechers put out? The Walk Rights or Stride Rights or something like that? Shape Ups, thank you, there it is. That's what rocker bottom foot is. That definitely would cause a problem with your gait, wouldn't it? It's going to help your back. No, it doesn't. Vertical talus is common. Pes cavus with a high arch. With toe clawing is really common. These patients, when they get that super high arch, the toes curl under. So now they have that high arch, but instead of walking on the toes, they're walking on the top parts of the toes, right? The dorsum of that toe. And that can cause problems. And then ankle valgus is really common. Genetic predisposition for this. So if you have a family member that has had a child with spina bifida occulta, you have a chance of having a child with spina bifida occulta. Low levels of maternal folic acid, right? What is folic acid? What is the generic term for folic acid? It's vitamin B. Good, right? It's just one of the vitamin B. That's why a lot of prenatal vitamins are high in vitamin B. With an asterisk, you still want to make sure you're taking it with prescription because vitamin B can still become teratogenic if you take too much of it, right? Certain ones. Most of the vitamin B, if you take too much vitamin B, guess what happens to the vitamin B? You pee it out, right? Especially for any that take a multivitamin and then 2 hours later you're in the bathroom and your urine is nuclear yellow in color. It's usually because you're peeing out most of the vitamin B you just took in, right? And that's also why when you consume lots of alcohol, your urine gets a little bit darker because number one, kidney function's down. Number two, it's robbing your body of vitamin B. That also affects your energy levels, right? Maternal use of valproic acid is really good. What can cause this, right? It's really good at causing this to develop. So any type of anticonvulsive med. So what type of patient might take anticonvulsive meds? Epilepsy, good. There are some really, really, really good signs and studies that are showing that people that take low levels of CBD for their epilepsy, that's okay. I won't forget. I'll forgive you for spelling. Take low levels of CBD for their epilepsy that are having great reductions in their seizure activity, that low level CBD may not affect the child. There's some studies that are starting to look at, does CBD cross over the maternal cord? And so far, they're not thinking it does. Now, THC does, and THC is a form of CBD, but not all the CBDs cross over that maternal cord, right? So specifically the Charlotte's Web strain, I think I talked to you guys about, I talked to you guys about the story of Charlotte and that, right? Charlotte Fig, I think I talked to you about after she died the other week. Child that their parents developed the Charlotte's Web strain of CBD to help children with epilepsy. It's really impressive. But I mean, that's some good studies that, instead of having to take maybe this with valproic acid is a real common epilepsy med, they can take a small dose of CBD and it'll reduce their overall seizure rate. Yep, exactly. Right. So if tremors reduce, that tells you it's working on what, do you think? Not necessarily working on dopamine, the opposite. It's working on acetylcholine, right? So they're starting to look at, does that affect the acetylcholine levels? And maybe just kind of suppress or tamp it down a little bit so that you don't get that resting tremor and seizures. Some really great research going on in this, but I talked to you guys about this before. All that research is illegal. Prevention and precautions, we're going to watch for hydrocephalus and accumulation of CSF in the spinal cord vault. Arnold-Chiari malformation, do you remember what that is? Arnold-Chiari, great. It's where the brainstem does what? You're right on with the brainstem, Jenna, right? Or the bottom part of the brain. Where does it gets pushed out through? Yeah, it gets pushed down and goes through the foramen magnum. Yeah, so you got a little bit of it kind of protruding below the foramen magnum. That's going to definitely cause some problems, right? So brainstem structures are disabled or displaced in the caudal direction. CSF may not flow properly. All that can cause problems. Most of these kids have a latex allergy. Arnold-Chiari, yes. Arnold. So the Chiari-2 malformation is one of the types, but the most time you're going to see it is going to be in Arnold. It'll be diagnosed as this, Chiari. And you don't have to know the difference between a type 1 and a type 2. Just understand that a Chiari malformation is a protrusion of the brain down through the foramen magnum. That's the main thing you know for your boards. Latex allergies noted. Key thing here is immediate care. If they can take care of that child and take care of that meningocele and myelomeningocele at birth, the child will have a better chance of developing normal later in life. But if you have an occulta, it's hidden, so they may not be able to see that right off the bat. So they have to make sure they're doing all the necessary care for the baby. Preschool was instructed home exercise program, right? Exercise to facilitate motor development. Again, with all kids, right? I talked to you about this before when we talked about Down syndrome stuff, or not today, but before about Down syndrome. The earlier we get them walking, yeah, it happens, Jenna, and a lot of times it may be that they didn't even notice it. But the earlier we get these kids walking, the greater chance they have of walking later in life, right? If we don't get them walking early, probably not going to walk later. The CNS deteriorates, can get with tethered cord syndrome, hydromalacia, which is excessive fluid in the actual spinal cord itself, causing pressure and necrosis of the peripheral nerves. So all of this can happen. Typically, when you have these problems, tethered cord's more of an upper motor neuron, whereas when you get the hydromalacia, that's typically going to cause more lower motor neuron symptoms. School age, free play on the floor may be reduced significantly, so we've got to make sure we're teaching appropriate activities. Aquatics are great for these kids. Adaptive bikes are good. Anything that develops cardiovascular challenge, stuff like that. Adulthood, degree of independence was not related with the ability to ambulate or lesion level. So this is interesting. It says that just because they didn't walk, they may not say that they're never going to be independent. Well, that makes sense. We're a lot different than we were before, right? Now, if you don't walk, you still have the ability to do most things in life. Obesity is common. Social incontinence is common. Recurrent urinary tract infections, and a lot of times recurrent urinary tract infections leading to mental disorders because they're not taking care of them. Chronic ulceration, joint pain, hypertension, neurological deterioration, and depression are really common with these kids when they get to adulthood. I'm going to cut this now, and then we'll finish the rest of this tomorrow because I want to give you guys about a 10-minute break before Dr. O'Neill comes in. So we'll start tomorrow, finish this off, and then we'll move into, I think, tomorrow. What was my tomorrow? Hold on here. So tomorrow, why did that show up over here? I forget what tomorrow is. Tomorrow's something. Tomorrow might be, yeah, tomorrow's PNF review. So we'll finish this off tomorrow. All right, so take a break. Or you guys in tomorrow, Wednesday? Tomorrow is Wednesday, right? Am I losing track of my mind? Tomorrow is Wednesday. I was like, wait, why did you ask that? So I'm going to stop it now. We'll go back into this and finish this off tomorrow.